So what I want to do is I want to talk about, the interrelatedness between pain, substance use disorders, and mental health issues. I want to talk a little bit about systems theory and how that applies to what we're talking about. And then, the other part is I want you to walk away with hopefully a different way of looking at these disorders and issues, different way of looking at your patients, and most importantly, a different way of looking at yourself and how you show up with your patients. So the reality is the behavioral health world is silent. There we go. All right. So we have therapists and specialists who treat substance abuse disorders. We have those that treat mental health. And then we have those that treat pain. And that's a problem because they're not interacting. So one of the first things I realized when I was in the pain space was that pain doctors are terrified of patients with substance use disorders. And addiction providers were terrified if a patient showed up with a chronic pain complaint. And then, what was real clear as I started working with Lovett was that the therapists that specialize in mental health issues didn't really want to know how to deal with the substance use patients and vice versa. So it was really clear everyone's staying in their little silos. But that's not reality, right? The reality is that it all interacts. One of the things I often will tell my patients is that the body and the mind are not separate. Pain doctors, they'll treat this specific pain generator issue, and they'll completely ignore the fact that the patient has depression, anxiety, they have chronic pain, they're isolated, and people weren't dealing with that. And it's a huge problem. And then you have patients with mental health issues that may be dealing with their mental health issues with substance use. And you've got patients with substance use disorders, and everyone's focused on substance use, and no one's looking at, the other mental health components that may be driving it. And that's the reality. When we think about our patients, we need to think about them as patients, not specific disorders that we're treating. So there's a lot of denominators, a lot of common themes among all of these issues, whether it's pain, substance use disorders, mental health issues. We've got ACEs, right? Our adverse childhood experiences, trauma, genetics, learned family behaviors. It's interesting in the pain world, pain can be a learned behavior that's passed down from generations. And, we see that in coping systems, and we're gonna, we'll be talking a little bit more about systems in general, but like internal family systems, everything interrelates. We don't exist in vacuums. We exist in relationship to ourselves, to our other issues, to our physical stuff, to our emotional and mental stuff, as well as our family members. We've got lack of coping skills, stress, lack of support, whether it's financial or social or professional support, and then exposure in life events, right? All of these things impact, one, whether we have a protective effect against chronic pain, substance use disorders, or mental health issues, or whether we have an increased risk of developing those and the severity of it. So one of the things that we know is that pain, trauma, depression, anxiety, they're all linked. And so we know that patients who have early childhood trauma, physical, emotional, sexual, psychological, have a higher probability of developing chronic pain later, but they also have a higher probability of developing substance use disorders, as well as other mental health issues, and vice versa. And so all of this is interrelated. And so part of the reality is that we think our patients are showing up for one reason, and yet, and often people aren't looking at the other reasons that are playing into it and feeding it, or just co-occurring. And the concept of co-occurring disorders, and Ellen and I were talking about this earlier, years ago there were very few places that actually treated co-occurring disorders. And now, I think it's pretty much the catchword for most places, but there's a reason, because it's usually co-occurring. the pain world is finally starting to actually understand that as well, which is nice. So what's the primary experience at the core of all of this? Well, it's suffering, right? Whether you have pain or addiction or mental health or a combination of those, the core experience is suffering, right? As well as powerlessness and isolation. People don't, in the middle of it, no one else understands. I'm alone, my family doesn't get it. One of the interesting things, I was talking with our clinical director at Lovett, and her primary training was in mental health, or is in mental health. And she said the most interesting thing is that when we have break, the patients with mental health issues all isolate. And the patients with substance use disorders all get together in cliques. And it was really fascinating. And when we think about how things work, so mental health issues tend to be very isolating. We see that with chronic pain as well. With substance use disorders, we're a little bit farther along because of 12-step groups, because of support groups, because it's really, and generally, in the midst of our addiction, most of us tend to be a little more social and form bonds in that way. But we don't see that as much. But the core thing is suffering. And what's the primary emotional driver? Is fear. It's never gonna go away. This is gonna last forever. No one's helping me, and what if I have to live like this for the rest of my life? And everyone's going to leave me. And so the driver for a lot of the behavior also is fear. So when you start to think about how you show up for your patients, it's really understanding that, and what do most healthcare providers experience when faced with a patient with multiple issues? Fear. Oh shit, this patient's got chronic pain. I've got no idea what the hell to do, right? I saw their MRI, right? You know, there's just metal all the way up and down. But here they are, you know, they ran out of their oxycodone, 15 days early. That's not because of their MRI. And so, but it's the fear of, I'm swimming in the deep end and I can't swim well. So let's talk about the elephant in the room, right? So many providers only want clients that have the issue for which they are specifically trained, right? I do mental health issues. I do, depression, anxiety, bipolar disorder, PTSD, like that's my wheelhouse, and those are the patients I want. If you've got addiction issues, I'm really sorry, I'm just not your therapist, there's someone else. And in the pain space, it's like this all the time. Oh my God, the patient has depression, they're like, well, just talk to someone else. Or if they have a substance use disorder, unfortunately, they tend to discharge these patients. I've worked with Peter for years back in my previous practice, and that was one of the things before, in most of the practices, everyone would just discharge them, rather than address the other issues. And the other thing is many providers fail to see or address the other issues that are going on. So I've got my patient with their PTSD and depression and anxiety, but they mentioned that they've been drinking a lot more than usual. Yeah, I'm just gonna focus over here, right? Because this is what I know. And so without really diving in, without feeling comfortable enough to address these underlying issues, that our patients, the likelihood of our patients getting better decreases dramatically. And so that's on us. But this is pervasive, and it's something, I've seen it in the pain space, I've seen it in substance use space, I've seen it in a lot of different specialties in the medical area. We've also seen it in the behavioral health space. We're all comfortable with what we know, right? That's normal. And when we start to jump into this space where we're not really comfortable and we don't have a clear, certain answer, what do most of us do? We avoid it. But that doesn't help our patients, and it certainly doesn't help us. So get over it. What we really want, right? If you're a pain doc, you want a patient with a herniated disc that you could stick a needle in or do a spinal cord stimulator in, and they're happy and they go home and everything's awesome, right? You know, your substance use, you know, your SUD patient comes in and they've hit bottom and they're ready. They're like, all right, tell me what I need to do. And they're going to meetings and they're doing their work and they're showing up to all the groups and they're not drinking, they're using. And I mean, man, that's awesome. And we get those patients. And that's great, right? Like, love it. But that tends to be the exception, not the rule. And so the reality of what we want isn't what we have. And I mean, and COVID unmasked that to a level that is astounding, right? With COVID, we had this collective, societal, really global trauma that we really haven't recovered from. The stress, the job loss, the fear, the financial insecurity, the health insecurity, everything got turned on its head. The good part about that is it brought mental health and substance use disorders and all of these issues that no one has really wanted to acknowledge to the surface and made it a cultural and societal issue, or at least awareness, which also increased the demand for services, right? So the one thing I do want to tell you, it's okay. You don't have to fix everything. Everyone has their area of specialty, and there's not a ton of people that are really experts in multiple areas. And that's great if you can find providers who do that, but most of us are not. That's all right. You don't have to be a pain doctor and a mental health specialist and a substance use disorder specialist, but you need to know enough. You need to know enough that you can address the issues and engage your patients in a way that moves them towards health and also acknowledges what is. One of the biggest problems that we have in the healthcare system, and it's less in behavioral health than it is in the medical space, is my provider doesn't listen to me. They don't listen. They got 5 minutes, they're in, they're out, they already know what they're doing. They don't even pause for a moment to hear me. And I know the nice part with behavioral health is we're taught to show up and listen and engage and, you know, validate our patients' experiences, and that's wonderful. And it's important though that as we do that, we're not ignoring the other things. Because if we don't address them in our patients because of our own discomfort, again, we're hurting them. So it's really about relationships, okay? Have many people heard about systems theory? Some, yes? Cool. So, you know, systems theory is a larger concept that we're a network of interdependent subsystems, right? And that each subsystem influences the other systems. It's a holistic approach when we're looking at patients, right? So most are familiar with the biopsychosocial model, biological, psychological, social, and also spiritual model. And, you know, it's interesting the other thing is, you know, a change in one area impacts the others. And I really internalized this probably about almost 30 years ago when I was doing my oral boards for anesthesia. And it was the hardest test I'd ever done. And basically what happens is you go and they sit you down, and these people who wrote all the textbooks sit there and they grill you for 35 minutes on this patient. And it's crazy stuff. I had like a little 4-year-old boy with an airway problem and asthma who's choking on something, and we have to intubate him, but he's got this issue, that. And I remember reading that first thing, I'm like, he's gonna die. Because I don't know, you know. But really, as I was studying for this, I started to see things in sort of a 3-dimensional way. Because if I do this, that's going to impact this. And this then is going to change, and that's going to impact that, which will change that. So I have to do this in order to change that, which will do this, and then they can do it. And then they'll be okay. And so I started seeing things 3-dimensionally and the interconnectedness of it. I didn't realize there was something called systems theory at the time. It was just something that I started to intuitively get. And that changed the way I look at my patients. It changed the way I look at myself and my relationships. And Einstein was right. Everything is relative. It's all about things that are in relationship to others, and they all influence it. We don't live in a vacuum. Our conversation today, this is impacting everyone in one way or another. And then we're all going to go back and we're going to go out into the world and we're going to engage with people, and all of that impacts other things. So we all live in a system, we just don't think we do. And I passed, actually, which was really nice. I was very happy. Not one of those you want to do twice. So you are part of the system. It's not that our clients come and they sit down and we talk to them behind our degrees and they have the problem and we're here to help them and we do our best to help. Well, okay, that's one way of looking at it. But the reality is we are engaging with our clients and our patients, and they influence us and we influence them, whether we know it or not, and for better or for worse. So as you start to think about how we show up with our patients, start to think about things from more of a systems approach. What does that mean? Well, it's about reframing our clinical identities, right? One of the best things that ever happened to me was when I crashed in my addiction, I wasn't able to go back to medicine for over 5 years. So I got to deal with this concept, right? So I used to think of myself as, I'm an anesthesiologist. Like, that's who I am. And then I lost all of that, which was, at the time, the worst thing around. But the gift in that was I had to look at myself in a different way. And is that part of who I am? Absolutely. I'm also a husband, I'm also a father, I'm a friend, I'm a pain doctor, I'm an addiction. I do all of those things. They're all little pieces. That's not all of me, right? So when we talk about our clinical identity, how do you describe what you do to others? Well, I'm a mental health counselor. I'm a substance abuse therapist. I'm a pain doctor, right? That's normally how we do that. And one of the challenges I had when I first started my clinical practice was I was integrating chronic pain and substance use disorders. And this was in 2013. So the opioid crisis hadn't hit yet. Well, I mean, it had hit yet, but no one knew or was talking about it. And so people were asking me, like, what do you do? And I really struggled. I'm a pain doctor, and I'm an addiction doctor, and try to navigate taglines and marketing copy for what we do. And it was really challenging, right? And so eventually I realized, I help patients with recovery from chronic pain, whether it's with or without substance use disorders. It's still a little messy, right? Sometimes it's hard to describe it, but that's part of what you have to start thinking about. How do you describe what you do, and perhaps expand that? I help patients who have challenges or problems with substance abuse, pain, mental health issues, and any combination of that, right? Because the reality is most of us struggle, and most of our patients struggle with more than one issue, right? We know that the core experience is suffering, and we know that what's behind that is fear, and pretty much that is a common human experience. And so when we start looking at how we show up, remember that we may not necessarily just be treating substance abuse or pain or mental health issues. We're addressing fear. We're helping our patients reframe their relationship with those things. We're helping them ease their suffering, which is their experience of what's going on. When they sit down and there's suddenly a discussion about, oh yeah, and I did cocaine last weekend. That's interesting because you've got bipolar disorder. Let's just talk about this. Are you still taking your medications? Right? Which is a legit question. but there's also a lot more there. And so how we show up, consider changing that, or at least looking at it to expand how I'm engaging with my patients. What happens when other red flags appear? Right? One of the things that we do at Love It, which I really like, is we have patients that may be primarily in the mental health program, but we also have recovery support for those, because a lot of them are using substances, and sometimes it takes time, as we all know, it takes time to figure out what's driving what, right? And so meeting patients where they're at and having that, having that conversation with them about it, and we're able to start to address possible substance use disorder in addition, or maybe it's a known substance use disorder as well as. But when those other red flags appear, what do? Do you redirect back to the core issue that we're specialized in? Or are you willing to kind of dive into a little deeper end and start exploring that? Because as you start to explore, you may uncover more stuff, right? Well, what is that? That's scary, right? Diving into a new space is always scary. When I went back to my residency after 5 years, I was terrified of going back to do something that I was really good at, but it had been a super long time. So there was a lot of fear there. And I had people who were like, "You'll be okay." And they were right. So that's part of it here too, is our patients are afraid of diving in. Why do you think, so many of us, or the patients in therapy, avoid the really hard shit, right? Well, because it's scary and it's uncomfortable, and I'm worried about that they're gonna judge us, the therapist's gonna judge me, or I'm gonna judge me, and it's all this fear. So we as therapists can show up with our patients and acknowledge what is, and help them go into that deep end, but we have to be comfortable going out of our own comfort zone and getting in that deep end with them. And how might you respond differently than you currently do? How would it look if you secretly just kind of went to yourself, all right, I can do this. And then go, okay, so tell me about the cocaine. Was a friend, and they're going to give you a response. Either someone put it in the drink, or I don't know, never done before, thought it'd be interesting, right? Or, yeah, well, 3 of my friends that I used to hang out with showed up, and here we are. Okay, well, let's see how do you feel about that? What's going on? And then start to look it up and think, oh yeah, and I fell and I hurt my back again too. And suddenly it gets a little messy, right? But our willingness to kind of show up a little bit more, knowing that I don't have an answer for this. It's okay to not have an answer for it, but it's much more harmful to not acknowledge it, And part of it can be like, hey, look, I'm not an expert. We're working with your PTSD, we're working with your bipolar, and I'm really good with this. I'm not an expert in substance use disorders, don't know if there's something more going on, or is this a one-time thing, but let's start to explore that, and maybe I'm gonna bring in some people who can help me with that. Again, you don't have to fix it, but we do need to acknowledge it. Gotta own our own shit. Compassionately, right? It's part of the deal, right? We're humans, right? We have relationships. We've had bad relationships. We've been hurt. We've had great experiences. But part of it is we have to own our own biases. And that's hard, and that's uncomfortable, because no one likes to acknowledge that we have biases and prejudices and privileges, And I'm not saying that you need to own it to the world and publish it on Facebook, And definitely don't put it in a memo and send it to the rest of your team. But what I mean is, to ourselves, or if therapists have therapists, I'm always a big fan of therapists having therapists. because we all could use some help. Really, we can use help with perspective on things. And being able to look at what our biases is doesn't even necessarily mean we're going to change it. But at least we know what's operating under the surface. Because it's the same thing with our patients. How many people have had like clients who do not trust the medical system? Who don't even want to go. Why? Because I don't trust you more, right? Like, I've had horrible experiences. You know. I always chuckle, my wife hates doctors. And didn't know I was one when we met, which was a good thing. But because, and I've seen it over and over again, such negative experiences with people going through the healthcare system. And it's a hard system to navigate, especially for people with no experience in it. And that's true in behavioral health. And so those biases are there in our patients, they're there with us. What are our insecurities? You know, I worked really hard to be this therapist. I worked really hard to be this physician. And I need them to know that I'm competent, that I can do this, right? Our insecurities are real. And it's okay, we all have them. So it's important to own them so that we know they're there, because that's driving our behavior. Our beliefs drive our behavior, whether we're aware of them or not. Working on seeing these, and when I say compassionately, I mean without judgment. The same way we show up with our patients, right? In a non-judgmental way. When I was doing anesthesia, I'd have a patient, and I would tell them, I'm like, look, I don't care if you shoot heroin in your eyeballs, you know, left eyeball or right eyeball. I'm like, I just need to know so I can keep you safe. And they're kind of taken aback, because it's like, look, dude, you know, somebody smoke crack socially. Okay. No, I mean, and fine. I just need to know so I can help you. You know, I'm not here to call the police. I'm not here to judge you. Just want to help. And if you don't tell me, I can't do that. And we need to do the same thing with ourselves, right? We have those ugly parts we don't want to show anyone. We all have them. And it's uncomfortable, and those are the warts. But just acknowledging them and owning them and showing up for ourselves the same way we show up for our patients can help us show up better in both instances. And our competencies or lack thereof. I'm a pretty good pain doctor. I'm a pretty good addiction doctor. I'm not the best one in either. Love to be, but I'm not. At the intersection of those, I'm really, really good. And I know that. But I also know where I'm not. And that's okay. Knowing what we're good at and what we're not, that's fine. But that doesn't mean I can't dive into the uncomfortable space. The part I'm most uncomfortable with is the mental health side. Why? Because I was never trained in that. You know, I don't have as much experience. I am more uncomfortable in that space. Really good on the addiction side, right? And so for me, my uncomfortable zone is over there. And that's why I talk to my colleagues who are experts in that, who understand that, because they can help me. And the reality is, you actually know more than you think you do. And that's like when I go back and I would talk to addiction providers about how to deal with a patient who shows up with pain. And you go back to that experience of suffering and the fear and the powerlessness and the isolation is the emotion, you know, are the drivers, is fear. And when you kind of frame it in that way, you're treating, you know, so your patient now has pain. Okay, what are you dealing with? You're still dealing with fear and suffering. And if you're not an expert in pain, that's okay. There are other experts that you can call in to help. But acknowledging that and owning that matters, right? Because if your patient's not heard, and again, if you don't have trust with our clients, you have nothing. And the likelihood of them getting better is really, really low, right? Because trust builds with hope. If they don't trust us, you're not going to get very far. They may be compliant, but they're not going to get better long term if there's not a relationship that is real and based with trust. And that's okay, again, about not being an expert in everything. We don't get connected. And what I mean by that is when you start to look at your patient and engage in our clients in a way from a systems approach, when we're looking at the whole patient, right? And it's not just pain, substance use, mental health. It's their family systems. It's their social situation, right? Married, divorced, their domestic violence, if there's legal issues, there are other stuff. All of these things impact our patients. And so as we're looking at all these things, understand they all interact. The more stress we have, the more it worsens other things. We've known since the 80s, right? The old type A personality and, stress can cause a heart attack, right? Something we can't feel or touch can cause a very real physiologic event that kills you. So we're really clear. We know as the more stress we have, the harder it is to handle stuff that happens in life. So as we're looking at our patients, engage them from that perspective because it all matters. If we're not dealing with the other stress parts in a patient with a substance use disorder and a mental health issue, how are we going to get it? It's like whack-a-mole. If you only treat the SUD, mental health's going to get worse, or the pain's going to get worse. If you only treat the pain or the mental health, the substance use is going to get worse, or the mental health issues are going to get worse. And if we don't help deal with the other stuff that's feeding it, meaning their other relationships in life, their relationships with money, with other people, with their job, it all feeds into it. So acknowledging and looking at those matter. Cross-training. So one of the things that we did at Love It, I was talking with our clinical director because we'd have a separate staffing for our mental health patients and a separate staffing for our substance use patients. I'm like, this is crazy, right? I'm like, because they overlap. And so one of the first things we did is we started staffing them together, right? Because the mental health folks, they're like, oh, I don't know what to do about these drug tests. And I don't know what to do about these patients. And, and the substance use folks are like, yeah, I got this part. And so we started doing cross-training or cross-staffing because the issues always overlapped. And then as we would discuss a patient, we'd bring up, hey, you see how this plays into this? You see how their drinking is impacting, how their medications are working for their bipolar. And so people started putting these things together, and the folks who were best in mental health started to feel more comfortable with the substance use stuff. And the substance use folks started to feel more comfortable with the bipolar or depression or PTSD or anxiety.
It also makes for a team.
Of course. We are a team, and you're exactly right. And that's that whole thing, is people start cross-training. People start asking their colleagues, hey, look, I got this, this patient's saying this. Does that mean they're using or not? So they'll ask someone on substance abuse. Because the overlap is really overwhelming. We did this in pain. That's why Peter and I worked together. Because until then, pain doctors just tried to deal with pain. But there's a huge psychological component to it. And so we would do staffings that brought in behavioral health with our pain doctors. I mean, it was a big far cry from when we first started, right?
Yeah, it was, yeah. But can I just say something?
Absolutely.
Yeah. So, and working in a pain management space and me being the behavioral health.
So they'll tell the doctor one thing, they'll tell the therapist another thing, they'll tell the social worker something else. And if no one's talking, we can't put the puzzle together. I mean, the entire SPY community had figured out that solution a long time ago, right? 5 different people talking to a different person, and then they all come back and they put their story together, right? We really need to learn from that. It's a great way to get a better picture of what's really going on with our patients when they're not in our office. Read about topics you don't want to. Like, yeah, I know, it sucks. I don't understand it, it's boring. do it, because you need to understand what's going on with your patient. If you don't understand, if you're not comfortable with substance use disorders, read a little bit about it. Again, you don't have to be an expert, but the basics really help and make a difference. And then ask your specialist colleagues. Talk to someone, pick up a phone. I tell the therapist, I'm like, and for me, you know, I've done a lot of work with drug testing over the years. I'm really comfortable with it, and it's a lot harder to interpret. And at first, people were making decisions on stuff. I'm like, whoa, hold on. And so we did, you know, I educated them about that. I'm like, give me a call if you see a test result that you're just not sure about. I'm like, call me, let's talk about it, so that you can actually learn from it, so that you're more comfortable in understanding how to interpret these, because we make decisions off of all of this stuff that could have a profound impact on a patient's life, right? Being discharged from a practice, accusing someone of relapsing off of a screen result, which is horribly inaccurate, right? But I've seen it. And that can have devastating effects, especially if we're talking about child custody or legal issues.
I saw a lot on it. I would do volunteer work on a neonatal unit. Newborns being taken away from their mothers because of those screens.
And it sucks, because it's unbelievably unfair and incredibly harming, and it's because of lack of understanding on the part of the healthcare providers. And so, and I didn't know isn't an excuse. How about we start to learn what we don't know? Co-manage patients. Again, like what we're doing is we have a primary mental health therapist, but we also have a recovery support person for the primary mental health if there are issues or concerns about a substance use disorder. So our therapists are now co-managing patients, which, I don't know, makes sense. You know, that was why I had behavioral health in my pain practice really from the start. Because co-managing is necessary, because we are people with complex issues. And ideally, if we can address them all in the same place, that's wonderful. I also want to acknowledge that there's a lot of places in which specialists may not be available, or the practice or the facility doesn't have the resources or the staff to have specialists in everything. That's okay too. That's when you call someone up. That's why we have telehealth, right? We don't have to go, well, we can't do that. No, you may not be able to do it in-house, but you can still do it. A lot of times, especially now where I'm not practicing pain management directly, but I'll have patients that show up at our clinic, you know, at Lovett, who have pain problems. So I'm able to address it on one level and refer them, if they need more involved pain care, that I can refer them to a pain specialist, and then we co-manage. I have a psychiatrist that I talk with on certain patients that we co-manage. Why? I'm not a psychiatrist, and I know that. Yeah, just ask my therapist. No, it's and so when I start to deal with mental health stuff that's out of my comfort zone, I call, you know, or refer them to a psychiatrist whom I trust, and then we co-manage, and then I'm learning from them because they understand that stuff much better than I do, and I understand the other stuff. So we start to teach one another, and get curious with your clients, right? So I know, especially, you know, with substance use disorders, most clients, none of us really want to own that, right? And, you know, sometimes they're not at a place of acceptance about the reality of the issue. But starting to ask our patients, and as we engage with our patients, help our patients think from a systems approach. You don't just have this. Well, how does this impact your physical health or your functioning? How does this impact your relationships? I mean, I would see pain patients and they would be there with their spouse. And, you know, someone was concerned about their opioid use at that point. They've been on for a while, and I would have this conversation. I'm like, so how's the marriage? And they're like, what are you talking about? I'm here for my pain complaint. And I'm like, yeah, well, you know, the medicines you're on emotionally blunt you. And if we're emotionally blunted, we often don't show up and we're not present in our relationships. And inevitably the spouse, husband, wife, whatever, the partner is like,
Yeah.
you know, they don't have to say a word. I just see the nod, you know? And so suddenly expanding their perspective about how things influence one another is important, right? I mean, again, the mental health issues are very isolating. No one understands. And pain seems to be the same way, right? And so helping talk with patients about how do you currently handle that? Do you just put it in a box? If we can help our patients not put it in a box and see how it's impacting others, and then start to work with different ways of integrating those things and understanding, because especially with substance use disorders, people are going to go out for reasons other than what is apparent or obvious. And if we don't address those, it's all the things underneath that's going to make a big issue. And then how does it feel to have more than one area of struggle? Well, how do we think it feels?
Sucks.
Fucking sucks. Yes, exactly. It sucks. Own it. Let them own it. I mean, for me, I swear a lot. It's one of those things that with our patients, being real and authentic with them about the reality of the situation makes a huge difference, because everyone dances around it. So I did my pain fellowship at MD Anderson, so it's all weird cancers, right? Like really weird stuff, and sometimes in really young people. And it was there that I really learned to just own the stuff that no one else wants to own, and help my patients do that. And I had a conversation once with a patient, like, look, I don't know how much longer you have. You have this very weird cancer. They were in their 40s, and they were overusing their pain medication. And the wife had come to me, and they're like, you know, he's falling asleep in his oatmeal in the morning, and we got, you know, 2 teenage boys that really need their dad. And my conversation with him was like, look, what you have sucks. It's horrible, no question about it. I have no idea how long you have to live. I don't know. But you've got 2 teenage boys who really need you. There are things you need to teach them and tell them for however much time you have. So how about we work on a plan? And I can understand why you don't want to feel, right? I wouldn't. But let's figure out a plan so we can manage your pain, but you can still be present enough to show up with your kids. And that was hard, but having those conversations and owning it with people makes all the difference in the world. And listening, letting them say this sucks and I hate this, is healing in and of itself. We're almost done, I swear. So what's the goal? Reframe the relationships. Look at things as the interconnectedness that they are, and that's really the path to healing. By looking at everything and owning everything for what they are. Help clients understand their relationship with their conditions and how it influences their relationships with themselves, with other people, with their friends, with their family, and with their other conditions, because it all influences that. And that's really where you can move towards functional improvement. Notice how I did not say cure. It's about living the best life we can live with whatever it is that we have, right? Wherever we're at, like, it is what it is. So setting realistic goals, owning what is. It was like with that patient, look, this is your situation. Your situation sucks, but let's make it the best that we can for what it is. Shared decision making. By engaging the patient in that way and letting them own it, they can be engaged in the process. It gives them autonomy. It gives them a voice. And that's really where healing starts. Because without it, there's no connection. And the harm reduction strategies, right? Meeting patients where they're at, right? Not everyone's jumping up excited to go to treatment or excited to take their medicines that it may stabilize them, but they gain 30 pounds or they just don't feel like themselves. I mean, who doesn't like a manic episode, right? However, there are consequences. And so, so meeting them where they're at matters. And it's relieving suffering, right? Again, addressing the fear and relieving suffering is physical, emotional, and relational. It's helping our patients reframe their relationship with their addiction or reframe their relationship with their substance use disorder or their pain, that can take it from this all-encompassing thing, like I am my disease, to, yeah, this is a condition that I struggle with. It's just a part of the bigger picture that is ourselves. Bringing collaborative efforts. Most of our clients need multidisciplinary care, right? It was like what I've been harping over and over again. Talk with colleagues, cross-refer, communicate, learn from them. You don't have to be them, but you can learn from them. And you don't have to discharge your patient or ignore the problem. You can actually engage with someone else who's really great at it and can help, and then you become better at it. And then challenge yourself. Think three-dimensionally, right? As the cover on my first slide was really the way that I started to look at things with all those little nodes like a three-dimensional globe. Everything's connected. Own your issues, keep learning. Start asking yourself, well, how does this impact that? What would happen if this happened or that happened? How would that impact this? How would it impact their relationship? How about their job? And then you can even engage your patients with that and ask the same question. You can be curious together. Cross-train, and if you can, in your facilities, try to integrate clinical staffing. Get your teams to work together instead of in the silos. And I want to end with, remember that one client. Everyone has that client that you made a difference. There was something that went on between them that you both walked away better for. The guy I was talking about was one of them. I've had a couple of those experiences in my life where something mattered and changed because of how we engaged. We can have more of those experiences, and they usually happen when we show up in an authentic way, all the bullshit aside, and really engage them. And when we do that, it shows our own vulnerability, and that's important. Our patients need to see that we're human too, and that we're vulnerable, and we're not perfect. But getting in there with them matters, and all of this is for that one client that we have, that it changed their lives, and it changed ours too. So that's what I got. Thank you.